welcome to our weekly echo session or GRT echo session. It's brought to you by the Gastro Foundation in association with the University of New Mexico. We've got 31 registrations today from 9 different African countries, but it's quality rather than quantity. So welcome to you all. Very happy to present Lesego Ndhlovu to you today. She is our newest pediatric gastroenterologist in South Africa. She trained the last 2 years at Red Cross in Cape Town, but she really is a Johannesburg girl, so it's just a matter of time before we get her back up here. And yeah, welcome Lesego, and we look forward to your talk.
Hi everybody, thanks Tim. Can you see my screen?
Yes, perfect.
Okay. Hi, my name is Lesego, and I'm going to be presenting a young girl who we had seen about 2 years ago and still in our services, and she was quite an interesting patient for us. So this is patient LM. She's a 9-year-old girl who was actually based in the Eastern Cape, but she came to Cape Town for what I think everyone had thought would have been a quick little visit to her mum during the lockdown, because her mom was living in Cape Town, and her mom noticed that she was actually quite unwell on arrival, and her mom brought her to one of our hospitals this side. She had diarrhea, she was quite weak. Mom also noticed that she was very swollen, and it was unsure how long she had been unwell for because she was not living with her mum. In terms of her post-medical history, we didn't really have much by way of any previous admissions, but we were able to find some results on LabTrack, and we could appreciate that there was an admission in 2015 in a hospital in Gqeberha, and she had quite a low albumin. Even her total protein was quite low, and she had a severe anemia of 3.5, and it sounds like she required a blood transfusion. But again, the circumstances around this admission were very scanty. And then it seems she had another admission in March of 2020. So in 2015, she would have been about 4 years old. And then around March 2020, she was around 8, turning 9. And we've got some information from our colleagues that side that she was admitted again, assessed as having severe acute malnutrition with edema and severe anemia requiring a blood transfusion. And biochemically, we could appreciate on LabTrack that she had what looks like refeeding syndrome with a phosphate as low as 0.2 at its lowest. But this was a very curious presentation because she was quite big. I mean, at 9 to be assessed as severe acute malnutrition didn't quite fit. And even at 4 years old to have such parameters. It seems she was lost to follow up because of moving, because of COVID and coming to Cape Town to see her mum. Again, we didn't really have much in terms of any past medical history other than this little bit of information we could gather online. We weren't sure about her immunization status. There was not much that happened post-delivery. She's never really had any other complaints that mom was aware of in the past. In terms of her social history, there was definitely some social constraints. She was living with her granny. And although there was some food security, there was limited dietary variety, but it didn't seem that it was really enough to account for the way that the child had presented. And of note, she had quite poor school performance as well. So on examination, this girl was really unwell, and she appeared chronically unwell. She was really wasted, and her clothes were very loose fitting on her. In terms of her vitals, she notably had the tachycardia with a bit of a borderline blood pressure for her age and weight and height. And her anthropometry, she was severely underweight for age. And she was severely stunted. And although her BMI plotted normally, She was clinically quite wasted, and just to note with her weight was that she was severely edematous, which of course would overestimate her weight. She really looked like a child who would have termed or classified a couple of years ago as having kwashiorkor, but she was 9. She was severely pale, and she had edema, lower limb edema above her knees. Her upper limbs were also edematous, and her skin was peeling. She had weeping dermatitis. She had very sparse, discolored hair, had oral candida, was quite a miserable looking child. And she had because of the diarrhea around her buttocks, she had this, what would have been termed a nappy dermatitis had she been in nappies. But the way that it looked and the distribution was, really exactly the same. So she really did look like what an infant with kwashiorkor would have looked like. In terms of her respiratory exam, she had a pictus excavatum. Mom said she had sort of had that since birth, but her chest exam was actually otherwise unremarkable. Her cardiovascular exam, she was tachycardic, and then she was in cardiac failure, had a gallop and an ejection systolic murmur, which we attributed at the time to the severe anemia. Her abdominal exam, it was not distended, there were no masses, she just had a 4 centimeter hepatomegaly, which was quite firm, but it was smooth. She had no splenomegaly. And then on her perianal exam, other than that nappy dermatitis kind of rash, she didn't have any tags or fistulae or abscesses or any fissures. Neurologically, she was not syndromic. And other than being quite weak, she had no focal neurology to note, and the rest of her examination was okay. So in terms of her blood work, you can appreciate she had quite a severe normocytic anemia. Her iron R was a bit deranged, and she really had a really low albumin, low total protein, on the background of a pretty bland, rest of her liver functions. So I did a few more tests on her. She was HIV negative. She also did some iron studies on her. It looks like she had an iron deficiency anemia. We were concerned about celiac disease given her presentation, but that screen, the TTG and IgA were negative. We also looked at her trigs, which were normal. We did a fecal calprotectin to screen for inflammatory bowel disease, and that sort of came back at 106. But of note, we did a fecal elastase, which was 74, and that with this mild to moderately increased fecal fat, we assessed her as having exocrine pancreatic insufficiency, and we thought, perhaps she's got cystic fibrosis or something else that, would account for the way she has presented. We also were up for TB, and that was negative. We excluded renal protein losses. Her dipstick and her protein creatinine ratio were normal. Her chest X-ray was essentially normal, and her echo, because of the cardiac failure, we just wanted to exclude any other underlying cardiac pathology, but that was excluded. Her abdominal sonar showed an enlarged echogenic liver in keeping with the fatty infiltration. And then of note, she did have this atrophic echogenic pancreas on the abdominal ultrasound. So we assessed her as being a 9-year-old girl who was severely malnourished, and she had edema and clinical stigmata of all these micronutrient deficiencies. We noted she had previous presentations of malnutrition, also edematous and hyperalbuminemic, severe iron deficiency anemia complicated by cardiac failure. And at that time, given the clubbing and the recurrent and sort of her recurrent presentation with nutritional deficiencies, and the fecal elastase, we thought she'd have, like I said, exocrine pancreatic insufficiency, query cystic fibrosis, and we were also querying if there was another primary cause or secondary cause of exocrine pancreatic insufficiency in her. To our surprise, her cystic fibrosis workup was actually negative. Her sweat chloride was fine, and her genetic tests showed no mutations. And then actually her fat-soluble vitamin levels were all normal, which was also a bit surprising, as was her lipase. Given that severe anemia, we also did an HP electrophoresis, which also came back as negative. So we weren't completely sure, but we managed her as, having some form of exocrine pancreatic insufficiency, whether it was as a result of chronic and recurrent episodes of malnutrition. She got some blood, and we rehabilitated her nutritionally, and she responded very well to the creon and the micronutrient replacement, and she gained, all her edema subsided. And she showed really good weight gain in the ward. We addressed some of the social concerns, and she was subsequently discharged to a step-down facility for nutritional rehabilitation. But she declared herself about 2 weeks later when she represented to the hospital, this time with painless rectal bleeding. And she never had any of this while she was in the ward, and she was with us for almost a month. For more than a month, and she'd never had any rectal bleeding, and so they noted some rectal bleeding, sometimes fresh PR bleeding. At times it was mixed with her stool, and at times her stool was also loose, but she had no accompanying constitutional symptoms. She was actually quite well in of herself, no fever, no pain, abdominal pain. She had received some oral antibiotics in the outpatients department, being treated as having some dysentery, but the rectal bleeding continued. Clinically, she really looked well. She had gained some weight, and this was weight without any edema. We were concerned perhaps she had a fibrosing colonopathy or some complication from the creon administration or dosage, but the dose was okay, and it was getting administered appropriately. She was clinically mildly pale. She had no edema at all. Still the clubbing that was noted at the first admission. On the rectal exam, she just had a small fissure at 4 o'clock, but not really enough to explain the amount of rectal bleeding, which was described as quite significant. She had a 2 out of 6 ejection systolic murmur, and then her abdomen just had hepatomegaly, but nothing else. It was not distended, no pain, no masses at all. So in terms of her investigations, everything was actually much better compared to her last admission, which is like 6 weeks sort of interval. Her HB had come up really nicely, as did her MCV. Her INR had completely normalized, and her total protein and albumin were also completely normal. Her stool was sent off for MCNS and was completely normal, including no white cells. Her elastase had come up beautifully to normal range. And then her calprotectin was now 3,000 odd, where previously when she came, it was about 106. And so we booked her then for a colonoscopy. And this is what we found on colonoscopy. She can appreciate she had large and multiple colonic polyps. These polyps were many and different sizes, and they were all the way from the rectum to the sigmoid, along the descending and the transverse colon. And she required polypectomy. We took quite a number of polyps out, and we sent them for histology during that admission. And there was nothing else that we noted macroscopically, no granulation, no inflammation, or any other features suggesting UC or Crohn's. Just interestingly as well, just prior to the procedure, she had a very severe bronchospasm at the gas induction. There was no history of atopy. She'd never had any bronchospasms in the past. And after seeing all these polyps, we weren't sure, we thought we were working with the differential of juvenile polyposis syndrome, and if this bronchospasm was related to an AV malformation, we could never really fully account for her digital clubbing. And so she proved to be quite an interesting diagnostic dilemma for us. So just as sort of we're working through her, I'm just going to chat a little bit about colonic polyps, which commonly present in children sort of in early childhood. Polyps can be sort of categorized by their histological type. So you can get your hematomatous polyps, and there are various polyposis syndrome under this category. So your hematomatous polyps can include your solitary juvenile polyps. So these polyps are almost always benign. And usually the presentation of these polyps is painless rectal bleeding, often bright red blood in young children. It's usually along the left side, the left colon, and it's usually polyps that are fewer than 3 to 5. Once you have more than 5 polyps, you're moving towards the category of juvenile polyposis syndrome, which I'll discuss in more detail. But these children have other extracolonic and extraintestinal manifestations, as well as some dysmorphic features. Then you get your PTN hematoma syndrome. So PTN being the actual genetic mutation. It is a tumor suppressor gene, which is important for apoptosis. So there are 3 sort of syndromes under this, including in children Proteus syndrome, which presents in childhood, and these children often get hemihypertrophies. But I think older patients in their 40s can have like Cowden syndrome, which usually these patients have a higher risk of breast cancer. Then your Peutz-Jeghers syndrome, these children often have mucocutaneous pigmentation. In addition to having intestinal polyps, they have large and small intestinal polyps, particularly in the jejunum, and these children may present with intersusception. And they often have, like I mentioned, these pigmented mucocutaneous pigmentation around their lips, and they may also have freckling on their face. Then your adenomatous polyps, so your familial adenomatous polyposis syndrome. These children have hundreds of colonic polyps, and there are also lots of extracolonic and extraintestinal manifestations of this, including in the thyroid, the liver as well, and it's very high risk of colorectal cancer. Then you get your MYH associated adenomatous or associated polyposis. These patients also have colorectal polyposis, very high risk of colorectal cancer as well. And this is one of the few autosomal recessive disorders where most of your other colonic polyposis syndromes are autosomal dominant. And then your Lynch syndrome is more in your adult population, and these patients have endometrial, they can have renal tract and brain cancers as well. Then inflammatory polyps can be seen in children with long-standing inflammatory colitis, and then patients can also have mixed polyposis syndrome. So these are just the 2 big groups of colonic of polyps. In terms of how these patients may present, the most classic presentation is painless rectal bleeding. They may have abdominal pain, particularly if they've got some obstructive symptoms, which they may also have. As I mentioned, some of these children may actually present with intersusception. If they have small bowel polyps, they may have altered bowel habits. So our patient had some periods of loose stools. They may have rectal prolapse. They may also have prolapse of the actual polyp itself. There's often a family history of cancers, so not just GI malignancies, as I mentioned, even with the FAP, those patients have lots of non-GI malignancies as well. So it'll be important to sort of tease it out in the history. They may have weight loss, particularly in the infantile syndromes. And then they may also have learning difficulties, particularly children with juvenile polyposis syndrome, as well as your PT and hematomatous syndromes. In terms of the clinical examinations, there'll be certain clues that might guide you towards a particular polyposis syndrome. So as I mentioned, your Peutz-Jeghers syndrome, these children have mucosal pigmentation, often around the lips and the tongue. The children with juvenile polyposis syndrome may have dysmorphic features. Also, those children can have severe anemia, hyperalbuminemia presenting with edema, much like our patient did. Extraintestinal manifestation, they may have thyroid involvement, hepatic involvement, sometimes eye involvement as well. So you might feel masses in the abdomen and masses elsewhere. In terms of, they may also have cutaneous telangiectasia. So typically with juvenile polyposis syndrome, one of the genetic subtypes, these children have cutaneous telangiectasia, and this may give you a clue about which polyposis syndrome you are dealing with. So looking at juvenile polyposis syndrome, which is what we thought our patient might have, it's quite a rare disorder. It is an autosomal dominant condition. And these children have multiple hematomatous polyps along the GI tract. So it's predominantly in the colon, but they can have polyps anywhere in the GIT. It is a precancerous condition, and these children are at an increased risk of getting gastrointestinal cancers, particularly colorectal cancer. There is often a strong family history of juvenile polyps, and in any child where on colonoscopy you see more than 5 polyps, you should definitely consider the diagnosis of juvenile polyposis syndrome, as it can't just be a simple solitary polyp. There are 3 different phenotypes of juvenile polyposis syndrome. So your most aggressive subtype is your juvenile polyposis of infancy. So this starts in young children, and these children often have other congenital abnormalities, which I will also go through shortly. They may present with diarrhea, with protein losing enteropathy. They may have rectal bleeding, interception, rectal prolapse. They may have severe hemorrhage and severe anemia. And these children can actually die before 2 years old in very severe cases. Then you can get your juvenile polyposis coli, where the polyp growth is limited to the colon. These patients may have acute bleeds, or they may have more chronic bleeds, and often the polyp sort of prolapse out, and it's often seen by the caregiver. These children may also present with anemia and present with diarrhea. And then generalized juvenile polyposis is where these children have polyps anywhere along the GI tract, including gastric and small bowel polyps. I mentioned some extraintestinal manifestations of children with juvenile polyposis syndrome, and some manifestations are more common in specific genetic mutations. So I mentioned, it's not really on this table, but some of the dysmorphic features. These children may be macrocephalic, they may have hydrocephalus, they may be hypotonic, they may have cleft lips, cleft palates, and polydactyly. Cardiac examination, they may have VSDs, mitral prolapse. Our patient had a normal cardiac echo. I mentioned that they may also have telangiectasia. This is in the specific genetic mutation where these children have AV malformations, and that's your SM84. These patients have telangiectasia on the skin, but they may also have AV malformations, not just pulmonary, they may have intracranial AV malformations as well. I mentioned some of the skeletal and cranial malformations. They may also have supernumerary teeth, intellectual impairment, They may have thyroid anomalies. They can also have alopecia. Our patient had quite sparse hair, whether it was a combination of her nutritional deficiencies as well as the syndrome. We're not really sure. They may also have some ocular abnormalities as well. So they may have quite a lot and a varying degree of extraintestinal manifestation. So in terms of the diagnostic criteria, of course, it would be a colonoscopy. So you would need to have a child who's got 5 or more juvenile polyps of the colon or the rectum, or if a child's got juvenile polyps in any other part of the GI tract, or any number of juvenile polyps in a child who's got a positive family history. Histologically, for juvenile polyposis syndrome, these children have hematomatous polyps, and it's often with normal epithelium, and these polyps histologically are mucus-filled, and they often have dilated glands. In terms of the genetics, really clinching the diagnosis really it relies a lot on the genetics, and the genetic mutation really helps in terms of the screening for the surveillance and screening for the siblings or the affected family members, but also in terms of screening for any of the extraintestinal manifestations. Some of the implicated gene mutations involve the SMAD4 and the BMRP1A genes, and then the ENG has also been described, but the first 2 are the most common. Often in majority of patients, you can actually find a mutation. The SMAD4 mutation is associated with your hereditary hemorrhagic telangiectasia and your AV malformation. So knowing that this specific genetic mutation will help you in screening for any additional complications and extraintestinal manifestations. Children with the BMPR1A mutation often have the more severe form, the juvenile polyposis of infancy, where they present early on with very severe anemia, bleeding, and malnutrition. And it's the presentation is quite variable and variable expression in terms of the mutation itself, and there's sometimes an inconsistent genotype-phenotype correlation. But it does help to get the genetic mutation, especially because it's present and detected in most vast majority of patients with juvenile polyposis syndrome. In terms of the cancer risk, most of the juvenile polyps are benign, but they can malignant transformation can occur. So it's important at colonoscopy to always send the tissue off for histology to just sort of check that the patient hasn't that you're not getting malignant transformation. And the lifetime GI cancer risk depends on the specific mutation that the child has, but by far the risk of colorectal cancer is the highest. And there have been some reports of gastric cancer incidence of up to 20%, but it's sort of still quite variable, and the risk or the incidence of gastric polyps is quite low in children in general. So in terms of the management of children with juvenile polyposis syndrome, the first thing, of course, would be colonoscopy and polypectomy. The main aim really of the polypectomy is to remove these polyps to avoid and to prevent any bleeding and any anemia. As I mentioned, these polyps can undergo malignant transformation, so it is important to remove them, as many as you can, and to send them off for histology. You want to remove all polyps that are sort of greater than 10 millimeters, and these children will require repeat colonoscopy every 1 to 5 years until all the polyps have been resected and removed. Most of the polyps in juvenile polyposis syndrome are right-sided. So it's important that at colonoscopy you try get all the way around, otherwise you might miss some polyps, which is in contrast to the solitary juvenile polyps, which are more left-sided polyps. In children who've got single juvenile polyps, you don't necessarily, it's not really recommended to routinely repeat their colonoscopy. And then in some severe cases, children may require colectomy, particularly in children where there's a very high polyp burden, where there's very severe hyperalbuminemia, and where the bleeding is excessive. But of course, this has to be discussed with the family, and it's, it would be a multidisciplinary team sort of discussion once you reach the colectomy stage. As I mentioned, the genetics are incredibly important, and patients with juvenile polyposis syndrome should be referred for genetic counseling and testing. And then predictive testing is important for affected families. And the screening and surveillance for polyps will depend on the presence of a mutation, if the mutation is known. And this is a nice flow diagram from the ESPGHAN recommendation from JPGN, and they recommend that in patients who in an asymptomatic child, if there's in an affected family, if there's a known mutation, then that child needs genetic testing, and if that child has the mutation that's known, the child would require colonoscopy by age 12 to 15. If there is no known mutation and there is a family member who has got juvenile polyposis syndrome, that child may require endoscopy anywhere at 12 to 15 if you don't know the mutation. And then if you've got a child who, now this is a symptomatic child who, if there's no family history, if you find more than 5 polyps at colonoscopy, then that child will require genetic counseling and testing, and to look for any extraintestinal features to support the diagnosis and to screen the others. So some children may require colonoscopy before 15 years old. So this is children who've got or relatives of a child who's got juvenile polyposis syndrome. And this is irrespective of whether the mutation is known or not. Some children who may require a scope beforehand, before 15 years of age. And those are children who've got severe anemia or siblings with severe anemia, PR bleeding, if they've got bad diarrhea, abdominal pain, if they've had any polyp prolapse, and if there's a family history of an aggressive phenotype, then you can perform the colonoscopy before the age of 15. Then in terms of looking for the extracolonic manifestations, so children with the BMPR1A mutation, I mentioned they often have the more severe juvenile polyposis syndrome of infancy, but they are the subtype that often get gastric polyps, but it's not recommended to routinely do upper GI surveillance, be it by scope or by MREs in all children with this mutation. However, any child who's got this mutation that's been found on genetic testing, if these children present with abdominal pain or gastric symptoms, then they may benefit from an upper scope to assess for gastric polyps. Patients with the SMAD4 mutation, so as I mentioned, those children are the ones that often get the hereditary the telangiectasia. They may present with the epistaxis and the AV malformation, intracranial hemorrhages. So these children do need to be screened for telangiectasia and for AV malformation. So they may have pulmonary AV malformations as well as intracranial AV malformations. So the recommendation is that these children get MRI brains at diagnosis, as well as contrast echoes to rule out any AV malformation. And it actually is also recommended in children where this mutation is known, to when at the time of or before any surgical procedure or any anesthetic, is to actually inform the anesthetic team of the risk of them potentially having a pulmonary AV malformation, as it may pose an anesthetic risk, which begs the question in our patient, if there was an AV malformation, which is what we were considering. So in terms of our patient, she did ultimately get an MRE, and we were looking for any gastric and small bowel polyps. So this is her MRE. She was on some iron supplements and had some feces in her rectum, but you can probably appreciate these hypo-intense, or these black filling defects in what would usually be the bright or the white hyper-intense fluid of the bowel. And these are the colonic polyps. But she had no small bowel polyps and no gastric polyps on her MRE. We did also do an upper scope on her, and she had no gastric polyps. And then her contrast echo also showed, it was normal. We didn't find any AV malformations on her, and her genetic tests were negative. Although we did not, I think those specific gene mutations were not, those have not yet been sent. I don't think we offer them here, but it might be worthwhile sort of motivating for for them to go abroad, because her sibling, she had her 16-year-old sibling, who's actually well, she is due to also be screened for this condition. So she was subsequently had another colonoscopy, which was done about a month after the first colonoscopy, and we found multiple polyps again, requiring a polypectomy, and they were still hematomatous with no malignant transformation. She's been scoped about sort of 3 to 6 monthly over the past 2 years, and there's been marked improvement in the polyp size and the polyp number, but still at her last scope in May this year, she still had a fair number of polyps, but much improved from when she first came. She's been weaned off her prion. She's actually been weaned off all her meds, but for her MDIs, because we could never really find a reason for this hyperreactive airway, that response she had in theatre, and she's presented a few times to the EC with bronchospasms, and we could never quite tie it all together. But she really did very well, and so that is our patient, and I'm happy to take any questions. I think she was quite an interesting patient for us as well, because she never had the rectal bleeding at the time that she was severely malnourished. And we could never quite figure out, is particularly the airway issue, the clubbing. We could never quite put it together. I guess the clubbing could be if she has this juvenile polyposis syndrome, and hopefully we can get some further genetic tests to help us clinch her diagnosis. These are my references. Thank you.
Thanks, Lesego. Very interesting case. I always think of how many children we just say it's kwashiorkor or edematous malnutrition, and we never look further, and many of them I think will have underlying conditions like this rare one you highlighted. I don't see any questions in the chat yet, but I just want to, perhaps it's more of a comment. Our ability to do genetic testing is still very, very limited, and recognizing that a lot of these patients, even in the first world, won't have a recognized mutation, it remains a bit of a unsatisfactory diagnosis for me. And the reason I say that, when I started out, I had a total of 3 children, which had mostly left-sided polyps. All of them were juvenile, and all of them had more than 5 polyps on their initial scope. We didn't find any extraintestinal manifestations, and we screened them a few times. Some of them had 1 or 2 more polyps, but other than that, they were asymptomatic, and eventually the polyps disappeared. And, by definition, they are juvenile polyposis syndrome, but they certainly present very differently to your patient. So, it would be interesting to get some whole exome sequencing on the whole family to see what's going on in these genes. Other comments?
Yeah, thank you. Tim, if I may. So Lesego, actually, I mean, the approach to children obviously is very different to adults. So what did you think the cause of her anemia was, hemoglobin down to 4 over a long period of time? I assume this was iron deficient?
Yeah, so it was a bit of a mixed picture, but it was, I mean, she certainly had iron deficiency. So, I mean, if we're going on the premise that she had, I mean, if that presentation, looking at her lab track history, she was 4 years old. So whether she had the very severe form of juvenile polyposis syndrome and she was bleeding, I mean, we don't know if she had rectal bleeding at that stage. She was living with her granny, but we could only, postulate that perhaps she was bleeding then. Perhaps it wasn't recognized because that would explain the anemia and the low albumin and the clubbing, the malnutrition. It would really explain it all, but we don't know for sure if she had bleeding at that stage.
And even if she didn't have bleeding, Tim, would you consider endoscopic evaluation in an unexplained iron deficiency anemia in an adolescent or a child with a hemoglobin of 4? I'm just comparing that to adults. I mean, adults, even if you don't get a history of rectal bleeding, I mean, endoscopic evaluation will come in very early in your evaluation where you find no other obvious cause. Just
myself. I think in peds we're a lot slower to do endoscopy, and obviously the etiology is quite different. So one of the things we've seen regularly is celiac disease. So certainly we'll test for that, and an upper endoscopy will come in early. And then we've had a few patients that keep on dropping their HB, and it's always a bit of a conundrum. And we end up looking for Meckel's diverticulum, and we end up doing red cell scans to see where they're losing the blood. And if there's access to colonoscopy, certainly they should get colonoscopy. But I think it's not like in adults where this is, one of the top line investigations that you would do.
So clearly a more conservative approach because of the invasive nature. And Lesego, just a point about the use of non-steroidal anti-inflammatories in patients with inherited polyposis syndromes. There's evidence that they do retard the progression of polyps. Aspirin, as you know, probably is effective in colorectal cancer, although it's very controversial as to the dose and when you start. But there is evidence using Sulindac in patients with juvenile polyposis. So you might want to consider the use of an anti-inflammatory, not to treat the existing polyps, but to retard the progression of the ones that you have, and also, the formation of new polyps. Obviously, you have to weigh the pros and the cons. There are risks to using anti-inflammatories, not only GI bleeding, but obviously other side effects. But that is something you might want to consider.
Yeah. I also wondered, and anyone can answer this, the use of pancreatic enzyme replacement therapy. It still confuses me. We get fecal elastases and they change from day to day, and depending on the consistency of the stool and everything. So I agree, there's pancreatic insufficiency. You should start Creon and see what the response is. But I do wonder, was it a solid stool? Was it was it diluted with fat? And I don't know if anyone's got any comments.
Okay, so that stool was sent with acid was formed, but I think there has been support for the use of Creon in children who are malnourished. So I mean, at the time, of course, we didn't know what her underlying mechanism was, but yeah, I think it is still an iffy area.
I thought I was going to get Liz to say her 2 cents. I know she's quite passionate about Creon.
Yeah.
Here we go.
No, I'm not so passionate about Creon, but I think there is evidence in those. There have been a few studies. If you're malnourished and you've got a low fecal elastase, I mean, it's short term. It's not forever. So I think there has been a better response, but you do want to make sure it's done on a solid stool and not an artifact from the diarrhea. So I think, yeah.
Correct. Any other comments? I don't see hands. There is a feedback form in the chat box, so we'd appreciate it if you give us some feedback. Going to give a last chance for anyone to raise any questions or objections, and otherwise we're off the hook. Seems like it. So what's left for me is just to say a very big thank you to Lesego for agreeing to come on and do this talk. Really appreciate it. We thank ECHO New Mexico and the ECHO India team for their tech support. Like I mentioned, feedback forms are available in the chat, and the recordings for our presentations are available on the Gastro Foundation website. So thanks to the Gastro Foundation and to the sponsors, and we look forward to seeing you again next week when we'll be discussing radiology. Thank you.